It will be a long talk on ventricular fibrillation is a normal heart. And first of all, for those non-familiarized with medical aspect of this disease, I will describe some very classical conventional syndrome. And we will finish the second part with new insight in patient who had a sudden death and normal heart. And we are outside this classical syndrome that we will first describe. Why to be fascinated by VF in normal heart? VF, ventricular fibrillation, as opposed to ventricular tachycardia, is consistently the arrhythmia associated with sudden death in patients without structural heart disease. When you take a patient with an abnormal heart, post-myocardial infarction or cardiomyopathy, most of them have sudden death due first to ventricular tachycardia, then moving to ventricular fibrillation. In that case, it's a primary VF, which is responsible for sudden death in patients with apparently normal heart. Yeah. What was strange is the most severe arrhythmia, because it's immediate sudden death. VF, despite being the most severe arrhythmia, has a more discrete substrate than VT, both by imaging or LV functions. And when you look at patients who had VF, they are between the characteristics of normal patient and on the other opposite side to VT patient. They are in between. If you take the QRS, the duration of the QRS in normal patient is about 90 milliseconds. In VT, it will be 130. They are in between. They have more discrete substrate, less abnormality. And idiopathic, as you know, we have to be fascinated because it's a cause of sudden death, and nobody in science or in medicine likes the word of idiopathic or unexplained. And something I think is idiopathic VF, in contrast to structural heart disease, where myocardial infarction is associated with a lot of different abnormality affecting depolarization, repolarization. Patient is taking medication, he has heart failure. Probably they have a simple elementary mechanism, by contrast to the other one, that I think deep phenotyping can disclose. And I will see all these different diseases associated with normal heart and VF as just showing one dominant mechanism. And if we can identify this dominant mechanism for this patient, it will be applicable to the wider patient with structural abnormal disease, like Rosetta Stone. About half of cardiac mortality is due to sudden cardiac death, and it's about 10% of human mortality in Europe or in other countries. This is, this very famous schema. This is the risk of sudden death is much higher in patients with abnormal heart, ejection fraction less than 30%, who survives cardiac arrest or risk factor. So these have a very high risk, but in terms of absolute value, they are less prevalent in the population, in contrast to a low risk in the general population, but the population is so wide that the absolute number is higher. It's a sort of paradoxical event. And what we know on epidemiological marker of sudden cardiac death, they give a lot of probability for population, but I'm convinced that if we do a very deep phenotyping, we can increase the risk stratification for individual. And what we know about electrophysiological marker is not so advantageous now, ejection fraction less than 30%, diabetes, renal function, and things like that. according to the last guidelines, the greatest challenge is to predict the risk of sudden death, particularly in the group of structural heart disease and ejection fraction more than 40%. These patients are now a wider population, but they are not protected by defibrillator because this is only for patients below 35% of ejection fraction. And the second high-risk group, the second group where we have to improve the prediction is patients like we will discuss now, which are the large population with no identified disease, and who can die of sudden cardiac death as a first cardiac event. We have different type of cardiac disease. I think we will see later. In structural heart disease, most of them, 90% have ischemic heart disease and cardiomyopathy. And we will see in detail, apparently normal heart and VF. This is about 10 to 15% of the population dying of sudden cardiac death. And we will enter in detail on all of that. This is in different population. You have in Denmark, in Sweden, in United Kingdom. In many countries, when you look at the patient below 35 years, the highest prevalence of sudden cardiac death in this young patient is idiopathic VF. We may have different diseases, but the highest number, this is something like 31%. In many countries, we found the highest number of sudden cardiac death in the young are due to unexplained sudden cardiac death. You will see in this slide. In fact, they will be available if you want to take many information and many ECG. In Netherlands, because we have Dutch people here, there is a national survey of sudden cardiac death, which is named Vigilance. There is also one in Canada, one in Japan. And this is one schema where in idiopathic VF, 20 years ago, we had a lot of abnormal patients who had sudden death with a normal heart. And we identify progressively long QT, CPVT, and with the new years, we have more and more new diagnoses. And now the number of idiopathic VF is lesser than what we have 20 years ago. I mean, by progressing in the phenotyping of the patient plus genotyping evaluation, we will have now a relatively discrete group of patients with idiopathic VF. In this paper by Visser and the group of Utrecht, you have many information. This is available in internet with a different setup diagnostic to diagnose idiopathic VF. Alors, the struggle for definition means that, by definition, idiopathic VF means there is no diagnosis. Donc, there is a list of examination you have to do to exclude any different type of heart disease and conclude, because they are all negative, it is idiopathic VF. And this is what we do in Bordeaux. We do a lot of phenotypic screening. First, exclude the structural heart disease, coronary imaging, MRI. We use different electrocardiographic means to exclude long QT, short QT, CPVT, Brugada. We will see all these diseases. And finally, to conclude, to idiopathic VF. But I will describe a group of patients, they are conventionally idiopathic VF. But if we do to deeper phenotyping, I mean by invasive mapping, we will disclose a second front of patients who had microstructural heart disease or Purkinje discrete activity. The role of genetic testing can be done in diagnostic, in prognostic, or in therapy. I will not expand on that. And I will go more on deep phenotyping. Now, you will see very impressive tracing of this patient. And what is surprising, when we do full evaluation of this patient with sudden death and who survive sudden death when they arrive at the hospital is sometimes we have just one small element in all this investigation. If you miss that, you miss the diagnosis. It's why I try to be very exhaustive, not to miss a pharmacological test. We have to do ashmalin, we have to do isoproteineline, we have to do adrenaline. And because if we miss one of them, we may miss the diagnosis. And I will show you some examples. This lady had, during horse riding, she had syncope. And to the point that it was so frequent that the physician thought she was a bit hysteric. It was the term pronounced for this lady. She was something like 45. And many investigations were all negative. And this is the isoproteineol test we did on the bedside. And you see here, we have no sinus rhythm. And at the first beat here, we moved to ventricular fibrillation. Donc she had a sort of catecholergic positive testing. And without that, the diagnostic can stay for a long time. Donc it was 15 years ago. She's on beta blocker, she's fine. And we didn't find any genetic abnormality. But the phenotyping was absolutely clear. In fact, at the time we wanted to deliver DC shock to stop this VF, she come back in sinus rhythm. And she said, "This is exactly what I have on my horse at home." Now, you see that. And this isoproteineol test is not so, is not in the conventional guidelines, but it is a very powerful test. Now, very classical. I don't know what is your experience in the tracing. This is a lady, 34 years, family history of sudden death, prior syncope. And she was referred because she had sudden death and resuscitated VF in a swimming pool. Look at the tracing. And this is a classical mean of a classical diagnosis in a swimming pool is during an effort, but swimming pool is suggestive of a long QT interval. And you can see here the long QT very clearly. And it was a familial sudden cardiac death story here and the long QT syndrome. It was the first one identified in the list of a patient with normal heart and sudden cardiac death. And there is now some guidelines. And most of these new diseases associated with normal heart are evaluated with a score. And the different score appreciate clinical or electrocardiographic criteria to define at some certain sum of point the probability high or low or intermediate to have a long QT syndrome. Syncope is the first presentation of congenital long QT syndrome. And a lot of patients have no symptoms. And this is sometimes a gray zone where we are uncomfortable. They have a long QT, they never had a story. So sometimes we have to decide if we will give a beta blocker or not to protect the person of a sudden death. This is sometimes a difficult medical dilemma. Congenital long QT syndrome. Something also for some of these patients, approximately 20-25% of with long QT, with genetically identified long QT, seems to have at the time of examination of normal heart. But we have to challenge the repolarization by different maneuvers to see if the behavior is normal or if you have some prolongation of the long QT, which is outside the normal range, outside the Gaussian curve. And in that case, we do, I think, we have different maneuvers. So we can put the patient upstairs, or we can do some Valsalva. And if you look at the QT here, oh, we cannot, can you put the, yeah. Merci. Yeah, you see the QT here. This is a standing up, I think, or Valsalva. It's a maximal. Look at the QT here. It's still very long compared with the acceleration of heart rate. Normally, it should shorten. It will not shorten. It was a sort of concealed form of long QT, a maladaptation of the long QT, and we give a treatment for this type. This is a very impressive case. The mother was 45. She had 3 times sudden cardiac death or very severe syncope. And we had no diagnosis. It was 5 years ago. She was a Black woman, and we did a lot of tests. Everything was negative. Look at the tracing. It's a perfectly normal ECG, normal repolarization. We did not find anything. And this is the son. The son is a basketball player. And we test the son just to see if we had something that could be familiar. Like the sister, I think, as the lady has died. And this is isoprenaline testing. So we see the long QT, but this is relatively normal in isoprenaline. But this was the shout, the diagnosis was there. I hope you see. You see here, you have a negative, 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 positive. You have a sort of alternating T wave here, and this is pathognomonic of QT alternance or equivalent. And we make the diagnosis of long QT just on this test. It was 5 years ago, and we had confirmation of a long QT syndrome a few months later. So the son allowed to have the diagnosis of the mother and all the family. Many different gene defects are responsible for this disease, which is typical by syncope during effort or during emotion. Different therapy. I will say this is also published a list of medication you have to stop, and the beta blocker is the main stay to treat this different form of long QT syndrome. Now this is more simple. A man, 22 years, sudden death, 2 syncope, and when you have the habit of ECG, you see immediately a short QT. A short QT is the opposite of long QT, but it's very exceptional. And this is also different side effects, so different defect in calcium channel, and it's very rare and often family history. But we don't see so much. I would say that we see 1 short QT for 20 long QT syndrome. But you see the tracing. You see the repolarization is here, and again, by comparison with what we had before. Now, very typical. This is a man. He was pushing his scooter in front of the hospital downtown, and he had sudden death, and it has been resuscitated. And this is very well known as the CPVT, catecholargic polymorphic VT. And it starts by acceleration of the sinus rhythm during the effort. Then this is typical. You have a bidirectional VT and then VF. And it is so reproducible that you put the patient on the bicycle, you do 5 stress tests, you will get 5 times this response. And it's a calcium ryanidine defect in most of these patients. It's pathognomonic to the point that if somebody describe a young man, a young lady with during effort a syncope, this will be very likely a CPVT. Diagnostic is clinical. This is interesting. There is no very specific marker on the baseline ECG. It's because you do an effort or you create an emotion that you will exteriorize, you will manifest the abnormality. Also, it's a rare disease, but you have not to miss it because otherwise the risk of spontaneous sudden death is very high. Mean age in Europe is 8 years at the diagnosis. Now, Brugada syndrome. This is more known because it affects adult patients. 10 men for 1 woman, prevalence of 5 out of 10,000 in Europe. Mean age of diagnosis is 45 years. You know probably what is it. The diagnosis is based solely on a specific but intermittent pattern on the ECG, and the type 1, which is this sort of repolarization in DOM, in V1 or V2, makes the diagnosis. It's based on ST elevation, to say like that, cover type elevation in one precordial lead in V1 or V2. And then we define a Brugada pattern. And after that, you have to see if this Brugada pattern is associated with a risk of sudden death, Brugada syndrome. And this is sometimes a bit challenging. You see the marker, you see a man without any symptoms, and you have to decide if you protect him or not. Among the tests, in some certain pattern, like what is called type 2, you don't have exactly the DOM aspect, you don't have exactly the 2 millimeter aspect. We can do Ashmalin, which is a sodium blocker, and that will help to manifest or not the syndrome. You can also, the abnormality is located in the RVOT, which is at this level. And sometimes if you put the electrode just a little higher, what was inserted in the classical standard lead V1, V2 will become obvious here. Now we use both high V1, V2 or Ashmalin infusion if we have some dust to diagnosis. The risk factor of sudden cardiac death, syncope, MAN, ECG type 1, and other abnormality. But you see here, you see three things which are, how can I say, not directly associated with arrhythmia. You see syncope, you see MAN, and you see ECG type 1. Syncope means you accept that the high-risk patient is a patient who already has manifest sudden arrhythmia. So this is a very typical dilemma. What we do when the patient has no syncope, if in fact he had a syncope, that means he had a VTVF, that means he had aborted sudden cardiac death. So we are really in big trouble to make some risk prediction in that case. What I would like to emphasize here, we don't have a direct marker of arrhythmogenicity. And in the lyric, for example, we try to understand beyond the ECG pattern, can we identify something from outside, non-invasively, that is more directly related to the risk of VTVF? Not simply the pattern, but within the pattern, something more specific by signal processing, for example. It was considered, you may have learned during this course, that there was a debate between repolarization and derivation or depolarization, the group of Nademani. There is now more evidence that to indicate there is first a depolarization disturbance, then the repolarization is only the consequence of depolarization. So you have to consider this disease as mainly a localized cardiomyopathy, mainly affecting the RV epicardium, and which is, because it's a depolarization abnormality, is very sensitive to sodium blocker that will increase the depolarization disturbance. This is a work we have done recently. I don't know if you see that. We are mapping the RVUT in a Brugada patient. We have a catheter here, and on the other side, endo-EP, we just put two catheters en face. This is what we record on the diseased part in the epicardium, and we record two types of potential. I see, you can maybe see with the asterisk, it is what we call the far field. The other one, the sharpest one, is a local epicardium. And we are delivering extra stimulus here. So you see we deliver one premature beat stimulation at 400 milliseconds. And you see we have a slightly delay in the latest part here. And when we shorten the delay, we have an increase in the delay. And what was a surprise, we have done in some patients, what was a surprise is it doesn't delay more and more. It disappears at some point. You can see here, this is at the beginning. And in fact, we have a completely abolition in some part of, in that case, it was here and here and here and here. We have an abolition, a disintegration of the electrograms, exactly like if you skip the schema here, we have a sort of black hole. Normally, it should increase and the depolarization should be activated by other way. In that case, it's like a black hole. There is a multiple small site of block. This is something very strange that is not common in other substrates like myocardial infarction or cardiomyopathy. Now, you can imagine in this RVOT, you have some hole that appear, and this is a very specific substrate, and we are wondering if this substrate is not more common in myocardial infarction and can explain the highest risk, for example, of VF. The management of Brugada syndrome also is according to some guidelines that you can easily find. Avoid alcohol, avoid cocaine, treat fevers, because fevers impair the conduction, before to take a decision of monitoring, device monitoring or ICD. Now we will go to the aspect of unexplained sudden cardiac death. How we can characterize VF mechanism in man. Some of them have spontaneous initiation of VF. I hope it's okay for you, yeah? We can map the triggers. We can just map what is a spark of the ventricular fibrillation, or once it has been started, we can map what is happening here during the continuation of VF by using non-invasive mapping and define where are the drivers, or by doing endocardial mapping. And you know that here with Olivier and all the group here, we can also work on human heart ex vivo. And this is the gold mine of information that we can acquire to understand at a very deep resolution the understanding of these patients. First, early repolarization. Donc, we will discuss about early repolarization syndrome and completely idiopathic VF. Early repolarization is something that is a slurring at the end of the QRS, particularly in the inferior leads. In the bottom of the heart, instead of having the QRS this way, there is a slurring that was called early repolarization, that it was interpreted as repolarization starting very early, just at the end of the QRS, instead of with a delay. And with a group of Bangkok, Lademani, Tsukuba, Nogami, we have mapped 48 men just to map this small part. We have mapped this 20 milliseconds with a catheter inside the heart or on the epicardial or endocardial part, just to see what is happening during this small triangle. And this is a man, sorry, yeah, voici on fait ça. Okay, I will go in this slide. This is a man who survived sudden cardiac death during the night, 23. He had a huge slurring at the end of the QRS. And when we map inside here, we have no depolarization activity, but we only have some repolarization. As expected, this small part is early repolarization. And this was defined not in all patients, but in a subset of them. That means the disease here is something affecting potassium channel like ITO or IKTP or something like that, there is a repolarization abnormality. In that case, quinidine is effective, and probably Purkinje cells are frequent triggers. But the surprise, but this is a more specific sign. This is one sister, Emina, who died here of this disease. And when you see at the tracing here, you see here, we have the slurring at the end of the QRS, and every time there is a short cycle, this disappears. Donc this is terrible. It was a terrible dynamicity of the early repolarization with a very high risk of death. You see perfectly here. It's not a bundle branch block. It's just a huge early repolarization appearing after the pause. And unfortunately, we cannot control the VF associated with this patient. And after hundreds and hundreds of VF, she died in this hospital, and we get the heart for the cadence program. And 6 months later, the second sister came and had the same thing. We could not control the VF. Once it starts, it never stops, despite quinidine, despite what you want. And we did a transplantation, and she died after the transplantation. So we get the heart of these two malignant early repolarization. And then we have a lot of information on that. This is what was unexpected. In some of the patients, the same phenotype, I mean slurring at the end of the QRS, is not due to early repolarization, but to a prolonged depolarization. The end of the QRS is simply continuing inside the ST interval, and this was a surprise. It was, you see here, the small hump here is occupied by depolarization. That means it's a completely different disease. It's like a brugada, an affection like that, in the inferior part of the heart. And most of them are also in the epicardium. This is a man, he's 19 years old. He had a VF while having a shower, and his father saved him. And you see here, it's a very tiny ST elevation in inferior here, maybe nothing else. And when we mapped this young man, we had a spot here in the inferior part of the heart. We was full of abnormal depolarization. It was just a small island, something like 2 centimeters, and enough to kill this patient. But you guess the treatment is different than the other one with early repolarization. In that case, we have done ablation because we cannot control by medication. And this is 2 cases of the cadence program. This lady had depolarization proven by fibrosis on MRI, by high collagen content. And this is an Emina with this abnormal repolarization in the endocardial LV. Just to see, we have the phenotype, we have 2 opposite diagnoses, and these have obvious implications for genetic interpretation. If you do in the same population, you put these 2 patients, and you try to interpret genetic. In one, it will be maybe a sodium channel. In the other one, a potassium channel. It's like you want to compare apple and orange. This is a big issue. So we are convinced that a very deep phenotyping will help us to decipher the different subcategory of this patient. If you have the same patient in most of the registry, they will be addressed in the same group. They will pollute absolutely all the results because we have different diseases. Now, idiopathic VF. We are at the top. I mean, everything we have seen before has been eliminated. Not early repolarization, not brugada, CPVT, etc. This is really patients like you and me, I hope so, and who had sudden death without any explanation. What can be the explanation? This is a subpopulation. It was 51 patients have been mapped. So we did exactly like we have done for early polarization. We decide to map endo, epi very precisely to see what is depolarization, what is repolarization, what is abnormal excitability. You see the mean age, it's 29 years old, 13 women, and majority of women. They are young. They are in the group of patients we have discussed before, sudden cardiac death in the young, less than 35. They are typically in that. And everything was normal, and we decided to do aggressive, in the good sense, mapping. And what we found is in most of them, 2/3 of them, this lady was walking in the street in Bordeaux. She had a sudden death, she survived. And when we map her, we found a small island with abnormal potential. Instead of, this is a normal depolarization, you see here. They are narrow, they are on time. In that case, we have a small part with this late potential, exactly like a micro infarction, like a micro brugada, like a micro cardiomyopathy. And this was the explanation. But it was so small and only on the epicardial site that it was missed by imaging or by anything. It's subclinical, but this was the explanation. And this changed the game because it's not the fault of God. It's just because you have a substrate that you have a risk of dying. This is a man from Canada. He was playing hockey, ice hockey, and he had 2 times during sport, he had a sudden cardiac death. And when he came, despite normal MRI, etc., we found on the epicardial side, in the left side, an island of abnormal activity here. You see, instead of having a nice narrow potential, you have a local fractionation. And you can see here, you see exactly normal potential here. And this you see late activity in a small part, in the inferior part of the heart. Donc these two small islets are sufficient to get, and we have applied that. But above the ablation itself, we can maybe design a method to detect this activity from outside and prevent sudden cardiac death. This was a big point here. Again, 2 cases, 23 years, survived sudden death, and we have just an island of activity here. If we do not do epicardial mapping, we said, okay, you are okay. We could not understand what is happening. If we do an aggressive mapping, we have the understanding of what is happening. And this was interesting, particularly for a Dutchman here. There is a disease prevalent in the Netherlands, which is a DPP6 abnormality, which is really something that is dominant in the Netherlands. And this DPP6 is a significant cause of sudden cardiac death in the young. And in the model, DPP6 is something that may impact on ITO. And the explanation for that is the ITO current is abnormal, and you get sudden death due to DPP6 mutation because you have a Purkinje excitability. And this is one of the men from Amsterdam we have mapped, and we had abnormality of the Purkinje, donc we had excitability which was abnormal, but we also had what was unexpected, a very abnormal activity in the epicardium. Donc the same mutation, despite the prediction, had a 2 impact on the Purkinje as expected, but also on the epicardial, like Brugada. Donc it changed again the perception, and it changed. The Purkinje cannot be predicted, but this can be mapped and then maybe found from outside. So you can differentiate among DPP6 mutation, the highest risk if you get this type of activity. Now, in patients with idiopathic VF, most of them have an abnormality. That means we have maybe 1 day, 1 min to detect this patient before they have the accident. But there is a second group, which is less prevalent, say 20 or 30%, where the patient died because he had abnormal focus, firing, most of them from the Purkinje. And you see here, example here, this is a lady, 90 years, she had Purkinje ectopy. She had a death on the beach during summertime. This patient, you see here, this activity inducing ventricular fibrillation. So this is more problematic. When we have the ectopy, when you see the ectopy, we can diagnose it. But we cannot predict which patient will be susceptible to get that. So this is something we have to work on. How can we design a drug that may, like ashmalin in Brugada, like isoproterenol for long QT, that can make it appear in patients susceptible to this Purkinje activity? We don't know what to do exactly. So we have just to wait record the occurrence of that to detect that. This is a problem, a gap in knowledge, a gap in our medical knowledge to detect this patient. In addition to this patient who had intermittent ectopy with a risk of sudden death, which is a minority, some of them we can, by pacing, we can also induce Purkinje. I mean, in a small group of these patients, we can, by pacing, create an activity within the Purkinje, a re-entry in the distal Purkinje. Like in this two patient, 46, a lady, 40 years, a lady. In that case, by pacing, we had a re-entry in the Purkinje, which was supposed to be the cause of VF. Again, everything else was normal. Without this mapping, we cannot have the answer. If we do that, we have a definitive answer on the cause. And just to expand on this topic, this is a patient with hypertrophic cardiomyopathy. We are outside the normal heart. You see here, we induce VF in this patient who had 4 episodes before with a hypertrophic septum. And when you see here, this 1, 2, 3, 4, 5, this 9 initial bit of VF, we found in this patient 9 Purkinje activity in front of this 9 activity. And every time we induce, it was always present. So in some of these patients, the VF start because it was promoted by some activity in the Purkinje, and this is a target for ablation. It's not maybe a target for prediction, but as risk for ablation. And this is very impressive. This man, 64 years, we induce VF. When you look at that, you said VF, but if you had a catheter on the Purkinje, you have a 21-bit full one-to-one Purkinje. And this was the step that accelerate and then promote the VF. This was very interesting because we have a way to induce this type of VF and a way to treat this patient. Now you have several components in this type of disease. I don't know what time is it. Yeah, okay. I would like now to summarize. This is a simplified pathophysiological classification of VF with normal heart. In fact, Brugada, some early inferolateral J-wave, and most of the idiopathic VF have something in the heart, which is an abnormal structure, which is an abnormal depolarization. In that case, we can maybe one day, by mapping from outside, found this abnormality in the propagation of the activation. This is by far the most frequent group of patients who has at risk of death. There is also a group of repolarization abnormality. That means the long QT, the short QT, or early repolarization. They are easier to find because the abnormality is most of the time frequent. This is something we can easily detect, while in that case it's still more difficult, it's invisible. And there is a small group of, say, 10% where idiopathic VF come from a small ectopic and intermittent activity. If you do precise phenotyping for each of these patients, for individual patient, you will improve the screening and interpretation of the different variants found in genetic genome wide mapping. And of course, it's completely different to ablate, to treat depolarization disturbance than a repolarization disturbance. To conclude, I would say VF, when you look at the literature, it seems that VF is very complex. It is complex. And there is a plethora of different pathology, structural, myocardial, fibrosis, inflammation, dysplasia, myocardial, electrical, genetic. This is a nomenclature of many different diseases. But if you look at the final pathway, it will affect depolarization in most of the time. It will affect repolarization in a smaller group and abnormal excitation in a smaller group. Thank you for your attention.
Thank you, Michel, for this very great talk. So it's now open to discussion, questions, comments. Yes, Mark.
Yeah, I have a question. I was really triggered by that you said that sometimes the beginning of VF is actually maybe it's a hereditary problem. We are now in the process. It doesn't work. D'accord. We're now in the process of extracting VF signals, real digital signals from ICDs, which have documented spontaneous VF. As you know, spontaneous VF is quite rare to register in an ICD, but we will soon have a few tens of these VF signals. Do you think that if we look at these VF signals, we can learn about what has caused the VF? And if we can we also apply this tip you gave us that maybe in some patients it's a His re-entry in the beginning? Is it something we can see maybe in these signals?
It's funny because we are in discussion of what you say. It's likely that we examine the initial, the onset of VF in this patient we had recurrent, including this idiopathic. Probably the one who we involve the Purkinje at the very beginning will have a short coupling, and we'll have the first bit. If you have a reentry in the Purkinje, you are in the highway of conduction, you will have a short cycle. And we are discussing a protocol where the coupling, but the measurement of the 5 initial cycle, where we may have a sort of discrimination between the different group. So we'll be completely happy to collaborate on that. All these unexplained sudden cardiac deaths, when they have a recurrence, we have a second chance to have a diagnosis on that. This is something we can do. This is a very good idea. Yeah. And the second question was?
No, it's basically the first question was, can we, if you only look at VF, try to learn something about what caused the VF? If you are in VF, does the quality of the signal, the speed, the cycling, the amplitudes, do you think you can use the signal of VF on its own to say something about the etiology?
Yeah. No, first for the initiation. And now I'm not completely sure that we can do by pulse mapping. I mean, by pulse mapping and looking at the ICD information, we can see where is the spot of beginning. Now we are not sure it will be the most critical part. In some of them, it will be the triggers, but in some patients, it's just something that will join a second spot. But it's something that we can do. And this has been done in the group of Frank Bogen. And he said that sometimes it's about 5 millimeter to 20 millimeter resolution. Because it's not so bad. You may have just by comparison some things that approach the site of initiation.
So we're still in the process of classifying the data, looking into the clinical records. What are the, but if the data set's complete and we have some results, we'll show you.
Olivier Bernus.
No, it's not a question, but maybe to complement what Mark was asking and also what Michel was saying is also the difference between the initial stage of VF and after a few seconds. So I'm not sure that, at least in the apparently normal hearts, once VF is established, from the VF trace actually tells something about the underlying mechanism. At least maybe Michel can comment on this, but after 5 seconds, VF becomes completely disorganized and not.
Fortunately, we have the first 5 seconds.
When we have a look at the mapping from outside, the initial 5 seconds gives more specific information on that. And then after, say, disorganized VF, ischemic, brugada, or idiopathic seems to be the same. If you take on a plug, you take some power and you had a VF, you will be disorganized and everything will be the same. It will be multiple wavelets everywhere disseminated. But the more specific information about the substrate is the initial organized VF.
We have to find the interesting window at the onset.
The first window. But what something we do not understand, some patients are okay. In some patients, it's just 1 second. That means you have a 4-5 bit, and then it's disseminated in 1 second, and then everything is irreversible most of the time.
So we actually have to look at varying windows.
Yeah. Probably we can do more with ICD information. Now, I don't know with subcutaneous ICD, the quality of electrograms is lesser.
For this project, I'm only in the cavitary ICD.
Yeah.
Other questions? Sylvain?
So, because it is your main research focus, what is the diagnosis capabilities of high-density ECG to identify abnormal depolarization? And does this tool has better results if we look at paced QRS than intrinsic QRS? I mean, do we see more abnormalities with this high-density ECG when, for example, the right ventricle is spaced or the left ventricle is spaced? Or
I think for this pattern here, we will progress. Maybe as the answer will be 2 to years. 2 to 3 years. For repolarization, it will be anything simple, I believe. And for excitability, I don't know exactly what to do. Excitability means the group of patients who had just sometimes the activity appearing on the ECG. They have very transient phenomenon, and I don't know what to do. Probably it will be some excitation from drugs or from things like that. But for this one, I hope what we are doing now with the system will allow to progress. We already have some proof of concept in some group. For example, in Brugada, in normal QRS, we have something from outside the heart that seems to be specific that we have just to confirm in the next month. So we are optimistic. But we are so far away that we should make some significant progress.
Other questions?
With Nicolas and all the group behind on the back.
Well, I have a comment. Maybe it's important for the students we have, is that you showed that you were able to make major steps into understanding of a major pathological problem because you took time to look in deep details, individual cases. So individual cases is something that give you the answers or clues to answer key questions. And it appears to me that you are now pushing the problem of VF into approaching normal hearts in the corner of abnormal excitation, which is the dark part, the blind part of this VF. And of course, there is a problem because, to my knowledge, it's 1 or 2% of the ventricular mass. So it's a very small mass within the tissue. It's spread everywhere in the myocardium. As you reminded, it's characterized by high velocity conductions. So it has all the characteristics that makes the diagnosis difficult. So, and there are the 2% unexplained, but maybe these 2% unexplained are within the abnormal excitation, because you explained that the pattern is intermittent, and maybe we pass. And of course, the localization is very tiny, so I guess it's very difficult to localize if there is a problem and where the problem is. So I don't know if there are secrets, but what is your vision, or do you have a vision on the way you can address the problem of the Purkinje tissue in terms of diagnosis and treatment?
I think when Bruno Spiver was in the lyric, what we have understood, there was a 4 different mechanisms, to say simple, to activate the calcium spark within the cells. It was not simple. It was 2 or 3 different scenarios, to say that. I think if we know exactly the type of activity, we may try to find some external agent like drugs that can, stress, challenge all this activity. I have not discussed, but we have about 20 patients. They had no Purkinje activity at the time where they come, and we have delivered some ashmaline, a sodium blocker. And the big surprise is the sodium blocker awake all this activity. So in this specific individual patient, we had a specific response, probably because we activate the initial mechanism. And the diagnosis of Purkinje risky situation for this individual was done by a sodium blocker. If we can find the different type of calcium activator, ITO, I don't know. So maybe we will be able to detect this patient. It will be this way. It's like asthma, bronchi asthma. You have different allergen that can be used for that. It will be something like that. Unfortunately, we are in big trouble in this institute or outside to map this Purkinje and to enter in this very difficult tissue to map at the level of the cell or at the level of the tissue. Donc, I don't know, this can be a huge progress, but we are in trouble for mapping and also to study the cells itself, unfortunately. And there is not so much group in the world to do that. But it will be the mechanism. We have to create the stress to activate the right mechanism. Otherwise, we cannot.
Okay. I have a second question. So you showed in your introduction that sudden cardiac death in the, let's say, normal population is something rather rare, but of course the consequences are dramatic. And the first episode can lead immediately to death. So you were showing lucky guys in some way. So, and this is a major problem. So, what is your view on the way we could screen patients who should undergo such sophisticated exploration? Are we condemned to secondary prevention to prevent an event who already occurred? Or do you think there is a way to go into primary prevention of sudden cardiac death?
If we put outside this specific subgroup of death risk, I would say that what has been discussed before, a non-invasive, sophisticated, adequate system maybe can do the screening because it's not expensive. It can be done. And probably the population for the proof of concept will be all the patients we had already with VF or with syncope. We can imagine a system that will be first addressed to patients hospitalized. And if the system proves to be specific, sensitive, it can be applied to the population, is what I hope so.
Okay. Well, no questions, no comment. Thank you very much, Michel, for your coming here with us today and showing all this data and the way you're thinking, the way you're advancing in medicine, and the importance of individual cases, going into the death of individual cases, which is your mark in some way.
Merci.
Thank you very much.